Namaskar, Hare Krishna. A very good evening to my respected teachers, mentors, mentees, enthusiastic audience. I welcome you all on the behalf of ISCCM Journal Club. And this is episode 3 of the series. And this initiative was initially conceived as a brainchild project of our President-elect, Dr. Ranveer Singh Tyagi. And he was basically having a mission where he encouraged each one of us to take the evidence-based medicine to the bedside medicine. And this is our honest attempt to simplify the evidence-based medicine to the bedside medicine so that we can homogenize the critical care practices across the country. I think Dr. Ranveer is going to join us in a due course of time. And this whole activity, this whole exercise is being executed under the direct guidance of my teacher, my mentor, Dr. Rakesh Garg. Dr. Rakesh Garg, I welcome you, Dr. Rakesh.
Thank you, sir.
So Dr. Rakesh is known as the name figure in the field of research and methodology in this country. And Dr. Rakesh is working in the capacity as a professor to All India Institute of Medical Sciences, New Delhi. And today we have two papers for the critical analysis. And the first paper is the critical appraisal of the A to B randomized control trial, which is there in JAMA 2025. And it is going to be mentored by my close friend, Dr. Devi Prakash Dash. Dr. Devi hello Devi, we welcome you. Dr. Devi is working in the capacity as an associate professor and senior consultant in the Department of Anesthesiology and Critical Care. Simultaneously, is taking care of this position in the care hospital at Bhubaneswar, Odisha. And the speaker for the first session is going to be Dr. Subradeep Biswal. So, Dr. Subra, I welcome you. And Dr. Subradeep is working. Yeah, thank you. So, Dr. Subradeep is working as an assistant professor in the Department of Anesthesiology and Critical Care at IMS and SUM Hospital, Bhubaneswar, Odisha. Right? The second paper is my friend, Dr. Neeraj, who is going to be a co-moderator for this session. Dr. Neeraj, would you like to introduce the second speaker and the mentor for this session, please?
Yeah, thank you, Dr. Manish, for your kind introduction. And yes, jointly we have started this journal club, and I think it's taking a good shape overall. And I think you have already discussed about the first paper. It's a very fantastic paper that we will be discussing, A to B randomized control trial. The second paper is also very, very relevant, constituting that the optimal role of vasopressin initiation. Basically, again, it is a very good paper that has been published in JAMA. And we have a very fantastic speaker, Ajay Rakesh Verma. He's a consultant anesthesiologist and intensivist, Medicover Hospital, Kakinada, Andhra Pradesh. And the mentor is itself our very lovable Rakesh Garg sir. And I think this paper is related to septic shock. So all our participants will be very, very enthusiastic to learn many things related to it. So without wasting not much time, I think we should start our first presentation. Thank you.
Yeah, thank you, Neeraj. Actually, we requested Dr. Ghanshyam to be a mentor for this session. However, because of, I think he has a commitment with the Higgs meeting, which is going on. So, of course, he was not able to make up this time. But very soon, I think he's going to be there as one of the chief mentor for one of the session. So we are going to start with Dr. Subradeep Biswal. Dr. Subradeep, just ensure that, your presentation is going to be for 20 minutes, right? So because it's a time-bound exercise, so please do respect to it. And please go ahead with your presentation. Thank you.
Thank you.
So you have to share the screen with us.
So let me know if I'm audible and my screen is visible.
Yes, you're audible. You just have to make it full screen.
Will I start, sir?
Yeah, please go ahead.
Good evening, all. Myself, I am Dr. Subradeep Biswal, and I'm working as assistant professor in some hospital, Bhubaneswar. And here I'm presenting this trial. This is the A2B randomized controlled trial where they have compared alpha-2 agonist with the baseline, which is propofol. So in the background, so propofol basically remains the most commonly used ICU sedative due to its cost effectiveness, randomized rapid onset, and ease of titration. And based on the previous data also, they have there's the estimate, they have estimated that by day 7, 53% of the propofol-based sedation would be successfully extubated. All the patients are successfully extubated, and 14 would die before extubation. And coming to the second one, which is alpha-2 agonist dexmedetomidine, it is an alpha-2 adrenergic agonist, and it reduces the delirium and shortens the ventilation duration. Though previously studies result inconclusive, and few studies like in SPICE-3 trial also, they have concern about the age-dependent survival effect. And the other alpha-2 agonist, clonidine, in this study, it is basically less selective alpha-2 agonist. It is cheaper and commonly used as an adjunct. And the evidence gap here is the head-to-head. There is no head-to-head comparison between these three. So the evidence gap led to the need of the rigorous trial, head-to-head trial, comparing the effectiveness of the study and safety of the clonidine dexmedetomidine as compared to propofol. So here are some studies that I have quoted, previous studies like MENTS, PRODEX, MIDEX, SPICE-3, Cochrane Review 2021, SCCM, PEDIS guideline, and MENTS-2, where all they have compared in the intervention arm, they have compared dexmed along with either with the lorazepam or the propofol or midazolam. And in conclusion, most of the studies, they have mentioned that dexmed reduces the delirium, coma, and some of them have also mentioned that dexmed associated with hypotension, serious adverse events like bradycardia, hypotension, and at all. And now coming to the research question. Here the research question is, does sedation with dexmedetomidine or clonidine compared to the propofol-based usual care reduces the time to successful extubation in critically ill patients requiring prolonged mechanical ventilation? So in this study, this is a pragmatic multi-center open-label randomized controlled trial with the 3 arms, 1:1:1 allocation. It is done in UK-based ICUs and 41 ICUs of UK, and duration was from December 2018 to October 2023. And coming to the core of the study, basically they have they have made 3 groups or 3 arms: dexmed, clonidine, and propofol, and they have 5 hypotheses to prove. The first, it is the superior plus inferior, non-inferior trial. So in the first hypothesis, they have compared clonidine, whether clonidine is superior to propofol or not in the for successful extubation. In the second hypothesis, they have tested whether dexmedetomidine is superior to propofol or not in terms of successful extubation. The third hypothesis was non-inferior. 3, 4, 5 are non-inferior, where they have mentioned, tested whether clonidine is non-inferior to dexmedetomidine. The fourth hypothesis was whether clonidine is superior to dexmedetomidine. And the 5th hypothesis was clonidine is superior to propofol in other secondary endpoints like delirium, the length of stays, etc. Okay. So here the inclusion criteria is more than 18 years, patient receiving mechanical ventilation in ICU and expected to have a mechanical ventilation more than 48 hours total, and sedated with propofol and other opioids after intubation, and within 48 hours of the intubation of mechanical ventilation. These are the exclusion. These are the inclusion. Coming to the exclusion, any acute brain injury, neuromuscular paralysis, bradycardia, and any hemodynamically unstable patient or expected survival less than 24 hours. Coming to the randomization part, it is a wave-based randomization, and with 1:1:1 allocation, they have used permitted blocks of variable sizes like 3, 6, 9, 12, and it is a computer-generated allocation sequence, and the allocation was concealed. Coming to the statistical analysis, initially they have taken 1737 patients to prove the superiority of alpha agonist over propofol, but due to COVID-19 pandemic, the sample size reduced to 1437. Though, despite of reduction, the power of the study almost 99% retained. And for non-inferiority part, they have taken power of 80% with a level of significance. One side is 4%, and non-inferiority margin of clonidine to dexmedetomidine by 1 day. These are the flow diagram which we have discussed. So these are the three arms. Coming to the intervention arm, basically they have two intervention arm. One is with dexmedetomidine, where they have started dexmedetomidine or clonidine immediately within 2 hours of randomization. And dexmedetomidine minimum dose is 0.7 microgram per kg per hour to maximum dose of 1.4 microgram per kg per hour. And clonidine starting dose is 1 microgram per kg per hour to maximum dose of 2 microgram per kg per hour. And they have targeted a sedation of Richmond agitation sedation scale of -2 to +1. And for any hemodynamically unstable patient, they have started with low dose. In the control group, there are no strict protocols, but the standard care practice with propofol to be continued with a target sedation of RAS of -2 to +1. In the both arm, they have not allowed any benzodiazepine and as a rescue, and opioids can be used, like alfentanil or fentanyl can be used. The common practices across the groups: RAS to be assessed every 4th hourly, CAM ICU score every 12th hourly for delirium assessment, sedation quality assessment tool every 12th hourly for behavioral pain behavior, and intervention will be continued till successful extubation, death, ICU transfer, or completion of 28 days of mechanical ventilation. So outcome studied here, our primary outcome was time from randomization to successful extubation. So by the successful extubation by maintaining spontaneous breathing without any mechanical ventilation more than 48 hours. Or if the patient is on NIV, then at least for 48 hours, a maximum of 5 centimeter water of PEEP or CPAP can be used. Coming to the primary and coming to the secondary outcomes. In secondary outcomes, the clinical effectiveness of the outcome, like all-cause of mortality at 180 days, ICU length of stay, RAS score more than -2, time to first day of optimum sedation, and rate of delirium. Apart from that, safety outcomes, then long-term and patient-centered outcomes like PTSD, anxiety, depression, cognitive dysfunction, and other collected data like rescue doses of medication, sedative opioids are used. These are the baseline characteristics. In this slide, they have taken Dexmed 457 patient in Dexmed group, clonidine 476 patient, and propofol group 471 patient. And the baseline characteristics are overall well balanced across all the groups, and the median time from mechanical ventilation to randomization is 21 hours. And the subgroup characteristics of age less than 64 are 59%, median pre-deliric score 73%, that is the delirium risk, and sepsis enrollment in 66%, and median SOFA score are 8. So these are what we have discussed, the baselines. Coming to the result. In the result, the primary outcome that is time to successful extubation in dexmedetomidine versus propofol group, the hazard ratio is 1.09 with a confidence interval of 0.96 to 1.25, which is including 1. So it is clinically, which is statistically not significant, but and with a p-value of 0.20. In the clonidine versus propofol group, the hazard ratio is 1.01, and it also involves the confidence interval includes 1, and p-value of 0.34, which is also not significant. So in the primary outcome, no statistically significant difference are noted, and because there is no statistical significance noted, so further studies are not pursued, like hypothesis 3, 4, and 5. So in this group, in propofol group, the median duration were 4 days. I mean, across all the groups, median duration are 4 days. and with a median dose of propofol 22 to 26 mg per kg per day. With the Dexmed total dose is 9 to 15 microgram per kg per day, and clonidine 15 to 22 microgram per kg per day. And the opioids used are also similar in all the groups. Now coming to the secondary analysis. In secondary analysis, the mortality of the ICU length of stay is 180 days. Dexmed versus propofol, HR of 0.93, 98. Clonidine versus propofol, hazard ratio 1.04. So there is no significant mortality difference. Time to ICU discharge are also 11, 12, and 12 days. There is no significant difference. Sedation practice also, the mean median of 2 nursing shift, each nursing shift of 12 hours in all the groups they have noted. And time to first day without deep sedation or agitation or pain are 3 days in all groups. And apart from that, agitation higher with Dexmed and clonidine group, which is statistically significant with the RR of 1.54 and clonidine RR of 1.55. And there is no difference in groups, in any groups regarding the pain behavior, rate of pain behavior, a rate of unnecessary deep sedation, or achievement of optimum sedation. So here are the then another secondary outcomes. Other secondary outcomes like delirium and coma. No, there is no significant difference between the groups. And the long-term outcomes, like there is no clinically significant difference between the health-related quality index psychological outcome. Yes, they have noted lower PTSD scores in clonidine group, but which is also clinically meaningful but statistically insignificant. The target RAS of more than -2 is achieved in almost more than in all the group in more than 75% of the patients. And coming to the safety, finally, the safety severe bradycardia noted in Dexmed and clonidine group with a RR of 1.62 and 1.58, and cardiac arrhythmia in higher with Dexmed group with RR of 1.27, and serious adverse event like more common with Dexmed group, and other adverse event like hypertension are similar across all the groups. So here is the Kaplan-Meier curve usually used for the survival analysis, and here they have mentioned the successful extubation over the period in all the 3 groups. And the key observation here, we can notice that the orange line, the dexmedetomidine group, shows a slightly higher probability of successful extubation within the time gap of 3 to 10 days. But overall, by day 25, 80 to 85% patients in all group had been successfully extubated. Here are the predefined subgroup analysis based on the age, sepsis, pre-deliric score, and SOFA. And across all the groups, hazard ratio hover around 1. That means there is no significant difference between the Dexmed, clonidine, or propofol group. Coming to the discussion, so Dexmed or clonidine is not superior to the propofol in reducing extubation time. Higher rate of bradycardia and agitation with alpha-2 agonist. Sedation quality otherwise comparable. Subgroup analysis also no interaction with age, SOFA, delirium, or delirium risk or sepsis. Strength of the study, it is a pragmatic trial design reflecting the real world ICU practice, and group-specific sedation algorithm used, allowing the individual care with the protocol within the protocol boundary. Low crossover rates, preserving the integrity of the treatment groups, and sedation target more than -2 RAS, achieved rapidly in nearly 75% of the patient, demonstrating effective protocol adherence. Comparing the sedation quality across all comparable sedation quality along the all agents, supporting clinical equivalence in all practice. And opioid use was consistent along all the groups. Benzodiazepine avoidance aligned the best practice guidelines, reducing the delirium risk. And real world challenges like COVID-19 staff shortage were captured and increasing the relevance. Coming to the weakness of the study, it is an open label design or with no blinding, so results are biased. Limited generalizability, that is outside the UK ICUs. Recruitment interrupted because of the COVID-19. There was no adequate weaning and extubation protocols, and protocol deviation and rescue propofol were used in dexmedetomidine group up to 77% and clonidine group of 76%. And limited clinician experience with alpha-2 agonist leading to shock, bradycardia, limiting the use. And deep sedation are requested to RAS of -4 to -5 in 25 to 30% of the study days. And patients, almost like 99% of the patients in dexmed and clonidine group were already receiving propofol prior to randomization, that is up to 48 hours. Coming to the clinical appraisal, study was valid, objectives were clearly mentioned, and the design of the studies were well discussed. In the methodology part, the blinding was not proper and they couldn't do the blinding. Funding was not so clearly mentioned, and there was possible bias because it is an open label design, and cross use of propofol was also there. In the result, the sample size, estimation, power calculation, were all discussed, and the outcome measure were properly defined, and the dropout data were there, and they have adjusted as the dropouts happen. And in the clinical appraisal, all studies limitations are discussed or not? No. The blinding limitations could have been more critically emphasized. And if the study is applicable to a local population, yes, but it is subjective. So the take-home points are how A to B trial might influence my study. The drug studied here we are using in India, and generally we also target a RAS score of -2 to +1, and propofol remains the same, safe and effective first-line sedative in ventilated patient, especially if the goal is predictable sedation with fewer cardiovascular side effects. And the study also supports continued use of propofol as a first-line agent, and alpha-2 agonist may be considered when propofol is contraindicated, or in resource-limited setting where we can use clonidine, but not as a preferred agent. And where we can use hemodynamically stable patient or a patient with a risk of bradycardia or resource-limited setting or limited monitoring, we can use propofol. Where we can use alpha-2 agonist, agitated patient, high risk of delirium, alcoholic withdrawal, elderly patient with no cost constraint and good monitoring staff support, we can use dexmedetomidine. Coming to the conclusion, neither dexmed or clonidine reduces extubation time with propofol, higher bradycardia and agitation rate with alpha-2 agonist, and propofol remain the safe and effective standard for ICU sedation. So some future scope. So clonidine optimization for optimization study in specific populations, biomarker guided sedation approach, and sedation and its long-term consequences we should study, and AI algorithms can also assist our weaning and extubation protocols. Thank you, sir.
Thank you, Subhradeep. A very nice presentation, bang on the time. I think you've taken it precisely 19 minutes. So first, I would request Dr. Rakesh Garg, sir, to give his insights and wisdom onto the given paper.
Right. I think, thank you, Dr. Manish Bharti, and thank you, Dr. Subhradeep, for this is actually a good paper. Now, a couple of things when we want to bring into a clinical practice. One, this protocol was made in somewhere 2016, 2017, when dexmedetomidine has entered the ICU care, and there were not many studies. So protocol, if you see the protocol, and if you see even the dexmedetomidine dose, which is a little higher side. So they mention about 0.7 micrograms per kg per hour to 1.4 micrograms per kg per hour. So this dose, the Indian population, especially more than one, is supposed to cause more agitations, more bradycardia, and more hypotension. And if you see the studies which have been published in intensive care unit for the use of dexmedetomidine for patients on mechanical ventilation in Indian population because of some genetic phenomena, a dose of 0.8 to 1 is more than sufficient. A higher dose of 1 causes those hemodynamic perturbations. 1. Second things that comes to picture when we start using it. If we compare, this was the duration. If you see, it was somewhere around, I think, 136, 140, and 150 hours, somewhere like this.
Yes,
So
sir.
if you
Yes,
say
sir.
150 hours, this means it will be around 6 days. There's something called propofol infusion syndrome. And this becomes more of an issue in patients who are critically ill with some amount of liver dysfunction that can happen in sepsis patient. So I couldn't see the outcome parameters related to the PIS, which is an important when we say whenever the propofol is infused for more than 48 hours, it becomes a major issue, and that leads to a lot of metabolic disturbances also. So this is the other issue that will, as the use of alpha-2 agonist over the propofol. Number three, when we talk about the dexmedetomidine versus propofol, is the amount of analgesia. Now, this was a pragmatic trial. And if you see the number of patients, they have used different category of patients. So they have certain exclusion criteria. But it was a pragmatic trial, which is actually good. If we talk about the surgical patients, propofol does not have analgesic action. On the other hand, dexmedetomidine has better analgesic action, which is better than the clonidine also. So if in 2025, I need to re-explore the study again on this background, and if you see the papers of dexmedetomidine, which has been used in clinical practice, though the hazard ratio that you show for the primary outcome and secondary outcome are comparable. But if we compare this trial, this big trial, this is actually a very good trial, with the other papers and try to analyze them into the series of papers, we will find that dexmedetomidine will take an edge over clonidine and propofol. So sometimes we need to interpret data into the existing literature. So probably in coming journal club, we'll try to incorporate some 2-3 similar articles published in last 2-3 years, so that we can come to a conclusion for our listeners that this drug is actually good or bad, or maybe other things. Last thing, we have talked about the mechanical ventilation part. And this, when we say mechanical ventilation, they need a definitive airway. And for definitive airway, the drugs usually use a propofol, etomidate, and nowadays also dexmedetomidine. Now, there are many studies which have been published, and recently there have been good papers where they have mentioned that the use of propofol leads to more amount of physiological derangement in patients who are critically ill, requiring airway management and subsequent to mechanical ventilation. So when we are using the drug, this means for these patients, we will not like to use propofol, maybe like etomidate or ketamine or thiopentone, or maybe a combination of dexmedetomidine with some opiate. This would be required. So this also needs to be in background, that though this is okay for sedation, patients on mechanical ventilation, but we also need to remember that this may not be the equivalent for initiation of mechanical ventilation. So these are a couple of points which comes to my mind. I think based on your clinical practice, start thinking of. But one important point I would say that please try to use a starting dose of 0.5 micrograms per kg per hour, and then you can titrate up to 1 mics per kg per hour. And in Indian scenario, do not give a bolus dose. They also have not given it. Do not give a bolus dose, because critical patient will show intense bradycardia and maybe an hypertensive response. So this is probably based on the other similar articles published from ICUs in last, say, 3-4 years. Over to you, Dr. Manish.
No, thank you. Thank you, Dr. Rakesh. In fact, you have already answered a couple of questions which I was already having. So we have Dr. Devi, and of course, we have Neeraj and Subradeep to answer a few of the questions. Now, it's very clear the evidence which we have heard with a lot of interest. Now, I just want to understand from maybe Neeraj, maybe Dr. Rakesh, and anybody can pitch in, that how you're going to use this evidence-based medicine to the bedside medicine with respect to the certain question. Help me in understanding, do you use fentanyl in combination with propofol generally in your ICUs? What is a common practice? The reason why I'm saying, because especially in this paper, they are talking about the concept of analgesia first and sedation second. So by and large, all the patients, they have received opioids, and they're also being, they are also being infused with either the dexmed or the clonidine or the propofol. I'm really, perturbed by, although it makes quite intuitive sense that you should be using both the sedatives as well as analgesia. But especially in the medical patients, Neeraj, what's your take? Do you really use the combination of fentanyl along with Dexmed, or do you really endorse this combination? And maybe Devi can also pitch in. Yeah, please.
Dr. Manish, actually, if we'll discuss this paper, I think in their limitation, they have already discussed about it, that in the patient who were receiving dexmedetomidine and clonidine, after achieving the optimal dose of dexmedetomidine and clonidine, they have continued the propofol sedation in those groups of patients. Okay,
Right.
so that's why they were not able to achieve that outcome that what were desired for. I think,
Okay.
but yes, you are very right, because they were primarily targeting of analgesia then sedation, and
Yes.
but for analgesia they haven't used any scoring system. They have used a RAS, Richmond Agitation Sedation Scoring, in which they have kept a target of -2. So in my practice, for few sets of patients, we very used to frequently use a fentanyl in our subsets of population for giving a sedation, and definitely dexmedetomidine in few of the patients, not especially in each groups of patients we used to give dexmedetomidine.
Okay. So thank you, Neeraj. Devi, what is your practice? Because it's very important. Remember this thing, we have a lot of mentees, we have a lot of students in the group. So do you really endorse starting opioid in combination with all the sedatives? And what is your practice in your institution?
Good evening, sir. Regarding the practice of sedation and analgesia in ICUs, in my last, let's say, 10 years of experience, being it a corporate hospital or a medical college setup, in all of those ICUs, I found opioids is the first choice. And in combination to opioids, I found rarely we use combinations.
Exactly.
In few cases, we can go to either Dexmed or propofol.
Exactly.
But
and I think Devi, you have already said it in a very, very handful of words. As Dr. Rakesh said that, maybe there is some differences, not some, in fact, there is a significant differences between the Western population and the Indian population. And that's why, they need to be both on opioids along with certain sedatives like propofol, because majority of the patients, especially in the medical ICU patients who have been sick, they cannot tolerate such a combination of sedation. One. The second is that if you start from analgesia first, like your fentanyl, majority of the time, they will not be requiring any access sedatives. So opioid itself should be able to take care of your RAS score, especially if you're giving them in a good, decent doses and titrating them to the RAS scoring. So generally, it is not going to be there. Just to understand, Devi, because you are a mentor for this session, it is said in this paper that the agitation was increased with Dexmed and clonidine in comparison to propofol. Now, this is very different and counterintuitive to our belief, because Dexmed generally should be able to reduce the agitation. There's another thing which they said, which even Dr. Rakesh has highlighted, that the rate of pain difference was not there in the three groups. Normally, when we are using, especially your Dexmed and clonidine, they have analgesic property as well. And especially in this paper where the doses of Dexmed and clonidine has been used in a good, decent doses, as Dr. Rakesh has been able to elucidate, then why there was no significant difference in the pain scoring, which is very difficult for me to understand. So two important questions, in case if Devi, you would like to give your opinion.
Sir, to answer the first question, the rate of agitation is higher in the clonidine and Dexmed group. If you see the previous studies, they say delirium is decreased in Dexmed and clonidine group. But I don't know why they have separated agitation from delirium here. Because we knew delirium has a component of hyperactive delirium. It can be hyperactive or hypoactive. But here they have separated delirium, level of sedation, and agitation. So as such, normally agitation in our ICU, we interpret agitation is either our target sedation is not achieved or the patient is in hyperactive delirium.
Here, I would like to differ, Devi, and maybe, we can discuss off stream as well. But if you read the PADIS guidelines, which is from Society of Critical Care Medicine 2021, they have given you pain, agitation, delirium, sedation, and mobilization practice as a basket thing. But these are all important, different elements which need to be assessed individually in any given patient who is going to be on any analgesic practices. So just to in the interest of time, if Dr. Rakesh or maybe Dr. Neeraj, In 2 minutes, if you would like to summarize this paper, that what should be a carry-home message for the students? Let it be a very simple, this thing, so that they can decide about the analgesia and sedation practices in their ICU. Yeah, please.
Yeah, Dr. Manish, no doubt that fentanyl is most commonly used or frequently used analgesics as a baseline in ICU setups. It's no confusion at all. For analgesics, there is no debate. But for selecting between dexmedetomidine and clonidine, I think Rakesh sir has told very well about that, the dose, the duration, that how long you have to use. But only one thing is that, because in this study also, they have not compared this dexmedetomidine dose-dependent toxicity based on the age groups, because it has been found that more age, more mortality on using dexmedetomidine. But a SPICE-3 study have already proven it out that in younger patient, if you are using a dexmedetomidine, the mortality is higher. So as per their effect. But what I feel, as per our practice and all, dexmedetomidine is one of the safest choice for using if you want analgesia and sedation both to a patient providing critically ill patient as that optimal doses. This is my take home from this good article.
And would you use the same drug both in the medical patients as well as the surgical ICU patients? Because I think somewhere it has not been bifurcated in this study.
Yes.
So what is your take? Because Dr. Rakesh is more dealing with the surgical patients. So what is your take, sir?
So I think if you see, even in this study, almost 2/3 of patients were from medical ICU, and approximately 1/3 patient came from surgical and trauma ICU.
Okay.
So probably that could be one reason that they found comparability between these ideas. Right, so maybe I put it this way. In addition to the other recent publication for the use of alpha-2 agonist in ICU, the surgical patient, and we have done one study where we have compared propofol plus fentanyl vis-a-vis dexmedetomidine plus fentanyl. And we have realized the outcome was not very big difference, but relatively better in dexmedetomidine propofol in surgical patients for extubation after 24 hours. So I'll put it on this background that probably in surgical patients, dexmedetomidine may be as better. In medical ICUs, it's up to you, as Dr. Neeraj mentioned, depending upon the individual patients, you can use propofol dexmedetomidine. But I would also put it that if the sedation is required for more than 48 hours, I would request that either it should be alternate, you can rotate the drug, or use dexmedetomidine. I do not have a data for this, that how the rotation works, but I feel that any patient requiring infusion for more than 48 hours, dexmedetomidine may be a better option as compared to propofol because of its metabolic delivery. So this is what I could understand from.
Thank you, Dr. Rakesh. But even your dexmed should not be used beyond 48 hours. None of the sedation has been recommended beyond the 48 hours. But as just to the paraphrase what we have understood from this, the conclusion, the conglomeration of the discussion, for all mentees, please must first give analgesia first. Analgesia is the topmost priority. Majority of the patient may not be requiring sedatives at all. If you're taking decently care of your analgesia, and opioids remain the drug of choice for them, and then you should be talking about any specific sedative protocol, either a propofol or your dexmed or clonidine, depending upon you have to choose your patient wisely in that given situation. There's a newer concept is coming up in the surgical ICU, which is enhanced recovery after surgery, ERAS protocol, and that is basically opioid free. That is something, another important perspective which we have to explore, especially for the patients who are on ambulatory surgery. I think we leave it in the interest of time. And let's, Neeraj, go for the second case, and then we can come back for the discussion.
Just prior to closing this discussion, I think many of the audience must be looking at this term A to B trial. Okay, so this A to B trial, just I want to answer in one word. That is basically, it's a clinical trial that is being used for testing the effectiveness of the drug. And if you are switching these drugs to evaluate the side effect, any resistance or any efficacy, for that A to B is being used, because you are switching from drug A to drug B. So this is, I think I want to add in the last. Thank you. So
Thank you, Neeraj. Please,
so now we are moving towards the next part, and I will welcome Dr. Ajay Rakesh Verma. And for this a very interesting OVIS study, I think we will discuss. Let's start.
Yes.
Because we are running short of time.
I think we should be able to complete in 20 minutes, because Ajay is very precise one. I know.
Okay.
Just trying to share the screen. Good evening, everyone, and it's very nice to be here. Trying to share the screen.
In the meantime, when Ajay is taking, Ajay, let us know once you're ready.
Yes, sir. Yes.
In the meantime, as Dr. Rakesh has highlighted, please be very, very careful in the patients who are hemodynamically unstable, especially because of the medical reasons. You should avoid using propofol. And even if you're using them, it should be certainly in a limited duration and used in the least dose, especially not in the cases who have been having a metabolic acidemia or a liver dysfunction. So please do not use it. Ajay, you are using, the screen is coming in a different way.
Yes,
yeah, now it is okay.
Please start. Go ahead.
Dr. Manish, you were pointing very time, and I think the sedation holiday principle should not also be forgotten. So,
yes,
I mean,
yes,
it's not continuous
yes.
infusion. Sedation
Yes.
holiday and rechecking of the patient clinical parameters as per the
Every day. Yes.
Right,
Yes.
right.
Definitely.
Thank you, Dr. Rakesh, for your inputs. Yeah, please, Rakesh. Ajay, please, you can go ahead.
Thank you. Thank you, sir. Today I'm going to present a topic about optimal vasopressin initiation in septic shock. We all know that we use vasopressin in patients who are in septic shock and who are not responding well with adequate fluid resuscitation, and even though after starting noradrenaline in the doses, higher doses. This study tells that it is trying to mark a differentiation between when to start vasopressin, and they have used a reinforcement tool to assess the line point of time when the vasopressin should be started compared to the clinician. And here we know that the septic shock is a combination of circulatory, cellular, and metabolic abnormalities, and the primary line of treatment is fluid resuscitation, antibiotics, and vasopressors, and the gold line of vasopressor of choice being norepinephrine, and to maintain a mean arterial pressure of more than 65. And source control is also the part that matters a lot. And in vasopressin therapy, the debate starts when many patients do not respond adequately to the norepinephrine that we start in them after giving the fluid challenge. And the escalation strategies are increasing norepinephrine dose or adding a second vasopressor, being vasopressin. And there is no clear clarity on what time should we start and what dose should we start in earlier studies. So that gives an importance to this study. And high dose of norepinephrine, we can always increase the norepinephrine dose in the patients who are in septic shock. So if you increase the norepinephrine continuously, and it can cause arrhythmias, and it can also increase the myocardial oxygen demand. Sometimes it may cause ischemia, myocardial ischemia also, and also it causes a severe peripheral vasoconstriction, which might also cause peripheral ischemia. And the gap in knowledge that we have now are when should we add a second vasopressor like vasopressin, or should we target an optimal mean arterial pressure strategy while multiple agents are used at lower doses? Or is there a benefit of fairly dual vasopressor strategy, like starting the norepinephrine and vasopressin earlier compared to previous ones? And the previous trials had mixed results regarding vasopressin use. So the VANISH trial, which was published in the New England Journal of Medicine, had an effect of early vasopressin, compared an early vasopressin effect with norepinephrine on renal failure in patients who are in septic shock. And there is no consensus on timing or criteria for adding a second vasopressor. The hypothesis made was early addition of vasopressin may reduce the norepinephrine dose requirement and minimize the side effects associated because of higher doses of norepinephrine. And it also showed an improved outcome like decreased mortality and morbidity. And the objectives of this study are to derive and validate a reinforcement learning tool that is basically an AI-driven tool. And the study is basically a retrospective observational study where they are analyzing a data of many patients from 2008 to around 2023 timeline. And all the they have taken from multiple hospitals, being a major hospital being the UCSF ICU patients. And the data was analyzed after putting the data into the machine learning tool, and based on that they have come to an output. So in this one, optimal initiation rule for vasopressin in adult and critically ill patients receiving norepinephrine for septic shock. And the reinforcement learning is a branch of, first I didn't have any idea about this tool or this study when I took up the study. Then I went into it and learned it's quite interesting. They have used a virtual agent to get an optimized set of treatment rules for good outcome. And they're well suited for complex dynamic problems like septic shock because it has multiple factors involved. And the methodologies reported according tripod A guidelines were used, and the collected data from 4 databases. And the reinforcement learning tool to identify the optimal vasopressin initiation strategy in septic shock patients receiving norepinephrine. And when the clinicians, how the clinicians are doing, they have compared them both. And this is the patient collection data chart. And the data preparation for reinforcement learning model was in each hospital, stay was considered as a single trajectory and distributed into 1 hour epochs. And these epochs are the intervals starting at 1 hour after the shock onset and stopping at the earliest of shock recovery, defined as more than 12 hours of being off norepinephrine or any other vasopressors, or ICU discharge, being dead or alive. And each patient was described by demographic characteristics, age, sex, and their body characteristics, race and ethnicity, and the SOFA scores, mean arterial pressure, serum lactate levels, norepinephrine dose, and fluid dose that is given before, and patients who are on mechanical ventilation, and patients requiring continuous renal replacement therapy. And they also have compared the Charlson comorbidity index score among these patients. Each 1 hour epoch was described by vital signs and the laboratory measurements, majorly being measuring the lactate levels, and the mean vasopressor doses administered, mostly the norepinephrine dose, and volume of the intravenous fluid administered, and the organ support requirements in these patients. Most commonly studied was the renal replacement therapy and mechanical ventilation. And the model training was given in the reinforcement learning tool, and then an algorithm was created, and it maximized the rewards over time by choosing actions based on the current state of the patient's condition, and defined the action for each epoch as a binary decision, like either starting vasopressin or not to start vasopressin. And the reward for epoch was calculated as a weighted combination of in-hospital mortality, changes in the serum lactate levels and mean arterial pressures, SOFA score, and the norepinephrine dose that was required. And the statistical analysis was done with the continuous variables and categorical variables. For descriptive analysis, the significance level was set at 0.05, and the model performance was evaluated using weighted importance sampling, and compares the reward obtained and the reinforcement learning rule with the reward obtained from the clinician observed action. And the primary outcomes they observed were comparing the reinforcement tools with the clinician. The vasopressin initiation at a serum lactate level greater than 4 was done. These are all the clinician guided things. And the norepinephrine dose greater than 0.7, and mean arterial pressure less than 65 mmHg, and for more than 12 hours from the shock onset. And the secondary outcomes was use of mechanical ventilation and renal replacement therapy during the patient trajectory. And the results were, the vasopressin was started at a mean SOFA score of 9, and a median 5 hours duration after the shock onset, and a norepinephrine dose of 0.37, and the serum lactate level of 3.6, and in-hospital mortality ranged from 28 to 43%. And the clinicians began at higher norepinephrine dose, requiring more organ support. And these are the comparative charts, where the vasopressin initiation for clinician observed actions and the reinforcement learning tool, where we can see the reinforcement learning tool has opted for earlier vasopressin initiation compared to the clinician observed ones. And the in-hospital mortality in the both groups were almost similar, but in the clinician model, it shows that clinicians opted to start vasopressin later compared to the reinforced model. And the discussion is a multi-center study where 232 hospitals and 14,453 patients in septic shock from multiple databases was taken. And the study derived, validated, and tested the clinical implications of a reinforcement learning model for vasopressin initiation in patients with septic shock already receiving norepinephrine. And the reinforcement learning rule was associated with higher reward and reduced in-hospital mortality when compared with average clinician actions. Enhanced clinical decision-making for the initiation of vasopressin in septic shock was discussed, and suggests initiating vasopressin at a lower norepinephrine dose compared to the earlier initiating when the norepinephrine dose is higher, and finding the alignment with the subgroup analysis from vasopressin and septic shock trial, the VAS trial published in the earlier, which suggested the patients who received vasopressin may have improved outcomes in less severe septic shock. And the reinforcement learning tool for vasopressin initiation may improve outcome by capturing the subclinical features and initiating vasopressin. Exogenous vasopressin may compensate for the relative deficiency observed in the septic shock where the endogenous vasopressin production along with the cortisol production is decreased. And it reflects the increased clinical vigilance and aggressive monitoring, potentially leading to improved outcomes. The prior studies like the vasopressin when compared with norepinephrine as the initial therapy in septic shock, either in the VANISH trial or the VAS trial, demonstrated vasopressin's catecholamine sparing effect, which is like when we start vasopressin, we can come down on the norepinephrine doses, which can cause the tachyarrhythmias or the peripheral vascular complications because of profound vasoconstriction, and which may reduce the adrenergic burden, lowering the risk. And vasopressin also increases the glomerular filtration pressure, lowering the need for kidney replacement therapy, where it increases the glomerular filtration pressure by contracting the efferent vessels. And the study did not prospectively test the reinforcement learning rule, and analysis did not include low or middle income countries with varying practice, and models were derived offline and evaluated using the existing data which was already existed, and models did not include any unmeasured variables such as infection source, and timing of the source control was not mentioned. And reinforcement learning rule recommended the initiation of vasopressin, but the dosing strategy was missed. And long-term outcomes among survivors such as cognitive dysfunction and the functional status of the patients, how were they after they recovered, was not compared or analyzed. And in conclusion, the study tells that in adult patients with septic shock receiving norepinephrine, the use of vasopressin was variable, and the reinforcement learning model developed and validated in several observational data sets recommended more frequent and earlier use of vasopressin than average care patterns, and was associated with reduced mortality. And future bedside use requests more RCTs to come to a conclusion and dose assessment of vasopressin. Thank you.
Thank you, Ajay. It's a very precise presentation which you have presented. Thank you for sharing the insights and the wisdom related to this paper. So, Dr. Rakesh, you are the, you are anyhow the chief mentor for the entire session. So you can always share your insights, and then have certain questions and certain clarification. Yeah, please.
It's pleasure to share.
Yeah, Ajay.
Thank you, sir. And
thank you. And the chief mentors, Dr. Manish Bharti and Dr. Neeraj Kumar, no doubt about it. I'm just learning from each one of you. So regarding this paper, I think this is an interesting paper. Thank you, Dr. Ajay, for presenting it very nicely and precisely.
Thank you, sir. Thank you.
A couple of things that we need to critically appraise is, when we talk of septic shock, there is no confusion. If you see the recent data, in fact, I will not say recent, for the last 10 years actually, it is more indicating the first line therapy always remains the norepinephrine. And if patient MAP is not being maintained or perfusion deficit is happening, lactate levels are increasing, organ perfusion specialist plaque circulation is decreasing, start on another dose, which is vasopressin here. one thing I just will add to it, because this, when we talk about the randomized controlled trial, this is for all the fellows who are listening to us. When we talk about the randomized controlled trial, always try to see that what group of or cohort of patients has been included into this. Though we are saying that addition of vasopressin to norepinephrine early is a beneficial effect, but remember that these were probably those group of patients who has probably maintained cardiac function. So if they have LVF which is decreased, there is global hypokinesia, if they are impaired left ventricular outflows or left ventricular functions, impaired cardiac function globally, probably in those patients, this combination may not be good. So in those patients, probably you need to avoid vasopressin. So this is one important message I should to give. When you read a paper, just don't read the primary objective and conclusion and start using it. See what patients they have done the study on. If you are working in an ICU where you are looking for the elderly patients who comes with cardiac failure with ejection fraction of 30, 40, 40%, be cautious about it, number one. Number two, definitely, I think no confusion. This will prompt us that early addition of vasopressin is important. And I will just take you a step ahead. You have started norepinephrine, you have started vasopressin, but you have to wean it off. Now, which to stop first? Now, this will not be in the reverse order. Now, when we say the effect on the blockers, it should be the noradrenaline, which should be tapered faster first, and vasopressin low dose needs to be continued and weaned later. So this is one when we talk of weaning, because finally we have to exit and not continue patient on vasopressin long. Third important point, if you see a couple of studies which has been published in maybe last 3-4 years, and if you see it was also in the sepsis trial, the use of phenylephrine. Now, phenylephrine is another agent which has been used in the critically ill patients, both for medical and surgical illness. It has not come into the exact first line or second line therapy, but people have tried to use it at second line. When we say second line, the first choice always remains norepinephrine in septic patients, septic shock patients. Now, there have been a couple of studies which have been published where they have compared norepinephrine versus norepinephrine with phenylephrine. And those studies say that addition of phenylephrine was not much. Probably it was, in fact, inferior one. So single use of norepinephrine was better. And probably that's the reason probably vasopressin comes into picture. And now we say that use vasopressin as second line. There had been another study where they have compared norepinephrine with phenylephrine versus norepinephrine versus vasopressin. Now, this study says that both are comparable. So somehow we have to interpret those things when we say the addition of second drug as vasopressin versus phenylephrine are comparable, but addition of second drug in isolation as isolated second therapy, phenylephrine is worst as compared to single agent of norepinephrine, a little higher dose. So these drugs are creating a little confusion. Probably we need more pragmatic studies, large higher group studies. But seeing all those studies which have been published, I think which Dr. Ajay Rakesh Verma has mentioned, if the cardiac function is okay, the first is definitely no doubt norepinephrine. But start thinking of adding vasopressin little earlier, rather than increasing the norepinephrine dose to maximum and then titrating it. And when you are reversing that, taper off the norepinephrine first, and then low dose vasopressin, and then taper it off. So this is couple of comments from my side.
Thank you, Dr. Rakesh. No, I think you have given already a punchline. But before I give my, the inputs on this paper, Neeraj, would you like to share some insights, maybe in the 2 minutes or something?
Yes. I think again, I will be very thankful to Dr. Ajay for such a nice presentation, first of all, and exactly what Rakesh sir has told. I have just a different aspects on it, because if you read that surviving sepsis guidelines related to that phenylephrine use, especially in patient who is already receiving corticosteroids, there is no role of phenylephrine as such as per surviving sepsis, because they are still silent on it that whether to use or not. But they have used at a dose of 200 to 300 microgram per kg per minute dose. My question is, that is very, very specific question with Dr. Ajay also, that what is the preferred, because here what they tried to use this the reinforcement learning tool, and based on that what they have defined, that they have started vasopressin at a dose of norepinephrine 0.7 microgram per kg body weight per minute, right? This is the dose after which they have started initiation of vasopressin, whether if the MAP is less than 65, So my question is, what dose of norepinephrine has to be started? What maximum dose of norepinephrine has to be started as per your surviving sepsis guidelines? And because this is very, very important for residents, still they are not aware about that concentration, how to use that norepinephrine dose, and when to add vasopressin. And then after that, if the MAP is not been maintained, you can definitely add adrenaline to it. And then after that, Rakesh sir was telling that in few studies, definitely phenylephrine is the last resort of drugs that can be added. But what my understanding is that I have got a very clear concept on that if the patient is underlying steroid is being used, the cutoff is already fixed. It is 35 to 90 microgram per minute for norepinephrine to start the vasopressin, but the dose what they have written is 0.03 units per minute. So this is the infusion dose of vasopressin to maintain a MAP of 65. If that doesn't happen, you can start with ADR straight away with a 20 to 50 microgram per minute dose, maintaining a MAP more than 65. It is not maintained, then definitely you can think of phenylephrine. But my question to Ajay is how to think of adding vasopressin, at which point of time, what will be the dose, in quick 1 or 2 words? Yes.
I think when there is a serious escalation of dose requirement of norepinephrine, even after adequate fluid resuscitation, and there is a continuous rise in both lactate, SOFA, and the noradrenaline requirements in the patient follow-up, I think that would be the time we should start. We should consider starting a vasopressin compared to maximizing the dose of norepinephrine.
So how much maximum you can think of?
I think it varies from patient to patient, because considering the patient comorbidities and cardiac conditions.
Here, I would like to pitch in, Neeraj. So there's something very, very important which we have learned from the more specifically the VASA study, the vasopressin and septic shock trial. See, the problem here is that the people, they use vasopressin when the patient is terminal.
Yes.
Now, we have to understand, it's our practice. I remember my old days from Indraprasad Polo Hospital, and I was basically used to be reprimanded that why I initiated vasopressin when the patient is still requiring and maintaining, the blood pressure on norepinephrine. And now, let me just give you the insight of, the 3 papers which they have spoken about. And of course, Ajay has already highlighted.
Yes.
See, if you really want to improve the patient morbidity and mortality, the use of vasopressin has to be as early as possible. Now, how early has to be early? The VAST trial, and especially this reinforcement learning method, what they have been talking about, you should use vasopressin as early as within the 1 to 4 hours. Ajay, you can correct me in case if I'm haywire with respect to the figures, but 1 to 8 hours is what they have been talking about. The reason what they are trying to reinforce again and again is use vasopressin early in the septic shock. The second important learning, which I want all the mentees to understand, use vasopressin in a less severe shock. Please do not use vasopressin when the patient is requiring a high dose of norepinephrine, because these are the 2 subset of patient, Dr. Rakesh, Dr. Ajay, Dr. Neeraj, where the use of vasopressin has been able to improve the mortality and morbidity, right? Now, when it comes to how should we decide on the basis of the dosage, now it's a very important question. As Dr. Rakesh said, let's say the patient who is coming as an acute circulatory failure, and the patient is having a rise in the lactate, low blood pressure and all the stuff, and you are suspecting that the patient is having a circulatory failure because of, let's say, the cardiogenic shock. There's no logic of starting this patient on vasopressin, right?
Yes.
So there has to be a clinical intuitiveness. So if I'm suspecting the patients to be an acute circulatory failure because of the sepsis as an intervening reason for my patient to deteriorate, these are the cases which should be on vasopressin. And please do understand, the role of vasopressin is not as a vasopressor at all. As Ajay has already highlighted, see, all the sepsis patient, it has been clearly demonstrated, not only in this reinforcement learning method, but also in the PASA study, more specifically the VASA study, where they have said it's a relative vasopressin deficiency which happens with them. right? In a patient with a septic shock, you're already in adrenergic excess. And this is the only hormone which has an adrenergic sparing effect. So you're using vasopressin not just to improve, the vasomotor tone, but also to replete the vasopressin deficiency, which also makes a sense that why you give hydrocortisone in a patient who is requiring, the multiple vasopressors. So, but one thing is for sure, please, which I have learned through hard means, and this paper is very close to my heart because I'm a very ardent, the follower of using vasopressin. Please do not use vasopressin when the patient is in the last stage or requiring supranormal doses of vasopressors. As far as the dosage is concerned, Neeraj, the dosage of norepinephrine on which the people they would like to use it, some papers they have said start as early as when the dose as early as when the dose is less than 8 micrograms per minute or something. So, generally in our practice, on the basis of the past evidence, we start when the dose of norepinephrine is more than 5 ml per hour, especially when you're using a 2 ampule in a 50 ml dilution. So this is what we use. And so the question comes with respect to the phenylephrine. I think you have already said, Neeraj, we don't endorse, especially septic shock, to use phenylephrine. The only indication where the people they may consider using a phenylephrine in a patient who has a highly supranormal cardiac output. And you have demonstrated through the non-invasive or the invasive cardiac output means where the patient is having, let's say, 10 liters or 11 liters of cardiac output, especially in the sepsis, and the patient is not responding in that given situation because the phenylephrine has a specific effect in decreasing the cardiac output. It does improve the arterial tone, but it may not be able to improve both the mortality outcome as well as, the physiological benefits in terms of the resolution in the lactate. So that is what, I wanted to share from my side. And I think by and large, we are through with the time. And thank you, Ajay. You share your second name with our mentor, the chief mentor, Dr. Rakesh Garg. Very precise. Yeah. We really enjoyed your presentation. And anything as a conclusive remarks would you like to share? I think Subradeep Biswal has a question. Risk of press 4 to 6 milligram per kg.
Actually, he has written a previous one. What is the risk of press? Yeah, he has written the dose.
I think it's an important thing which Rakesh sir also has mentioned. The PRIS specifically has to be seen in context to the patient who are critically ill. We are not talking about the surgical set of patients, Subradeep. So the patients who has been on vasopressors, which also makes a common sense that you should not be using a propofol in a patient who's already on vasopressors especially because of a sepsis. And especially it has been described in the pediatric age group to begin with. And we rarely see PRIS nowadays because, as Dr. Rakesh has elucidated very clearly, we rarely use propofol more than 48 hours. If you're requiring the sedation for more than 48 hours, it's time for you to ponder and reflect, why do the patient needs mechanical ventilation, by the way? So think in that perspective rather than just continuing the sedation endlessly. And Neeraj, do you have any remarks? Just otherwise we will wind up.
No, I think everything has been covered. Just to add 2 points related to that, because it's a new tooth for RL loop. That is your basically your reinforcement learning loop, and that's why this study has been different from other that what they have published. That's why only the reinforcement loop they have added, in which I think Ajay has very well talked about it. But actually, it has an agent. It has an environment and it has an action and state. The agent is basically like that it will be a decision maker. The agent will be deciding and the environment where the agent will operate. So based on that, they have used this tool, and I think it's a good study. We have a good understanding about it, and they have quoted that VAST and that VAST trial as well as Vanish trial also. So I think it's from my side, it's okay. And
thank you, Neeraj. And with this, because we have already 10 minutes past, the question is: can we add as vasopressin can be recommended cardiogenic shock, ACS, or ischemic heart disease? Anybody who would like to answer? Rakesh ji and maybe Ajay, Devi, or anyone. Otherwise, I will answer my opinion. Yeah, please.
Normally, sir, I also attach to a cardiac center. I'll take the question.
I think then you are the best person to answer, Devi.
Yeah. So there the practice is, if it's a pure cardiogenic shock, there is no component of sepsis. Initially, we go with NORAD, and if the patient is not responding or requiring high doses, then we go for ADR. So vasopressin in the pure cardiogenic shock, vasopressin is not being used. But many a times you will see a combination of both of these. Patient is in sepsis as well as there is a cardiac comorbidity. Patient came with a 30 40% baseline ejection fraction. So in those cases, it's very tricky to go for vasopressin or not.
Very nice.
Correct.
So I will just share because I was with the Prince Sultan Cardiac Center, Neeraj, and if you permit me, I would like to share my experience.
Sure,
Neeraj.
sure.
So as per ACC, American Heart Association, I think the last guidelines, there are 20% of the patients who have warm cardiogenic shock. By and large, when we say cardiogenic shock, it's basically the cold variety which we are talking about, right? 80% of them, they are cold variety. There's no role of vasopressin in cold variety of shock. As Devi has highlighted, in 20% of the patient, 1/5 of the subset, the reason of ACS could be sepsis in origin. Even sepsis can trigger ACS in patient. And these kind of cases will be seen by having a vasodilatory property. So you will see that the SVR is less in them. And although they have cardiogenic dysfunction, which you can demonstrate with the help of your, the non-invasive means, your transthoracic cardiac assessment. But in that given cases, especially if you find that the patient has a low diastolic blood pressure, which means that the systemic vascular resistance is typically less in this subset of patient. And these kind of cases can be given a trial of 0.03 to 0.04 units per minute, which is basically the fixed dose what we recommend. Another important thing, as somebody has asked, whenever you are initiating any inotrope or vasopressors, especially vasopressin, please see how the patient is behaving in the next couple of hours. So if you find that the patient has a resolution in terms of the requirement of your other inotropes and the patient perfusion markers, they're improving, as Ajay has already highlighted, by seeing the lactate and serial assessment. So, which means wherever the cases where you have chosen your vasopressin is working in the favor of the case. Otherwise, you can always take the U-turn. But by and large, please understand the phenotype of shock which you're dealing with. Cardiogenic is the one where we are afraid to use vasopressin. By and large.
Yes.
So with this, I would like to bring to the conclusion and to the end of this presentation. DCLD in septic shock requiring mild to moderate ARDS. Does vasopressin have added advantage for CLD? What is DCLD?
Decompensated.
I think decompensated
liver disease. Yes.
Chronic liver disease.
Yes.
I think
Decompensated
Supradeep
chronic
has
liver
already
disease.
answered.
Yes. This is one entity in liver patients. They survive on vasopressin and terlipressin. Please do remember, this is one patient. We have one file beyond HRS. For all the reasons they have to be on this. So thank you, Supradeep, for your inputs. And thank you to all mentees for attending this wonderful session. And I would like to say my special thanks to Dr. Rakesh Garg, who have been always phenomenally taking this exercise.
Always.
Rakesh
Sir is always there for us.
And of course, we are missing our President-elect, Dr. Ranveer Singh Tyagi, and a wonderful deliberation by Supradeep Biswal. Thank you, Supradeep, for taking this exercise. And of course, Devi, you are a great friend, great mentor. I love the way you have taken up this exercise. And Dr. Ajay, phenomenal presentation skills you have. You are extremely calm and extremely poised the way you have carried out this presentation. And Neeraj, what a wonderful man you are. You have been always a co-moderator of Flamboyancy. I really enjoyed having this moderation with you.
Thank you so much.
And with this, we bring it to the closure. Thank you, everyone. And please do join us for the third Friday of every month. The next session for this Critical Care Journal Club ISCCM is going to be on 18th July, right? And with this, let's wish you, everyone, a good evening and enjoy the month ahead. Thank you.
Thank you, everyone. Thank you, all speakers. Thank you.
Thank you for the opportunity, sir.
Thank you, sir.
Thank you.